So good afternoon. Welcome to the second in the series of how and why evaluation is important and can be important to you. This series is a result of part of HHS's response to the Foundations for Evidence-Based Policymaking Act. In response to that act as a requirement, we did a capacity assessment to assess the HHS capacity for evidence building. That includes data building, data capacity, evidence building in terms of evaluation, performance measurement, foundational fact finding, policy analysis, a range of things. In that capacity assessment, one of the things that rose to the top was a better need to understand evaluation amongst people who are not evaluation staff themselves or not the primary people responsible for evaluation. Sort of a, why should you be interested in evaluation and how can this be helpful to you? So this series, and I said this is a second in the three-part series, is focusing on that topic. And so we will cover how and when to work with an evaluation team, how to turn your need for information into solid evaluation questions and maximize the benefit of evaluation. And in the next session, which is next Thursday at the same time, we will talk about appropriate use of evaluation data to inform programmatic and policy decisions. So it won't be a statistical discussion per se, but how to know that the data are good quality, how to use those data, how to communicate those data. A couple of housekeeping things. The session that we had last week was recorded and we do have a PowerPoint. We will be providing the PowerPoint later in this session for those that want it from the last session. We will also be attaching in the chat a copy of the PowerPoint for this session. So you will be able to look at that while you're looking at the presentation. We will be recording this webinar as well, and all of the materials and recordings will be posted on one of the M.S.P.H websites, and there will be a link to them when they are available on the Evidence Building Evidence Act part of the M.S.P.H website. And we'll send out materials to let you all know when they are posted. And please submit questions through the question and answer tool, and we will get to those questions. Some we will answer on the fly in writing as we go through, but otherwise we will have time for questions and answers at the end of this session. So it is my distinct pleasure and honor, as last week, to introduce our speaker, Dr. Elizabeth Yano. Dr. Yano is an adjunct professor of health and policy management at the UCLA Fielding School of Public Health. Dr. Yano trained in healthcare epidemiology, biostatistics, and health policy at UCLA and RAND, has over 30 years of experience in health services, research, and program evaluation, and at UCLA teaches evaluation health services in the executive M.P.H program. And so while that sounds really nerdy, and she can be quite nerdy if she wants to be, she's also very engaging, and we're thrilled to have her here. So I will turn this over to you, Dr. Yano.
Thank you so much. Let me go ahead and share my screen. Can you see that all right? Great. So yes, as Dr. Jenkins mentioned, this is our part 2 on getting the information you need, and second of a three-part series for thinking about key principles of evaluation in the federal context. And we will have time at the end for questions and answers. So let me just dive in on when to work with an evaluation team. That depends on the type of evaluation needed and the availability of internal resources and expertise. Now, you may have within your program, your component, your agency, strong internal expertise, but it may be that you have difficulty redirecting staff to evaluation. Perhaps everyone's booked solid, or they may not have interest in your evaluation focus. For me, whether it's at UCLA or within my agency, finding existing faculty and staff in the middle of a fiscal year in particular can be really tough, as people often plan out their coverage and their projects well in advance. It can also be difficult to engage existing folks who have strong skills but also strong passions for specific topics, and if yours is not among them, you're going to have to keep looking. Now, it may also be you have internal expertise in analyzing survey data, but that may not equate to strengths in conducting qualitative interviews, for example. So if an evaluation includes survey data, you may want to consider an evaluation team that combines in-house agency expertise with external evaluator qualitative expertise. I'm afraid I speak from experience in this one. I have real strengths in big data and surveys, and I figured I could easily handle qualitative interviews, no problem. I learned I'm a better talker than a listener. Perhaps no surprise there, but the challenge was that I tended to get really excited about people's responses to the interview questions, and I started putting two and two together as I would speak with them, and I would start to feed back the things that I was learning along the way. When we listened to the audio tapes of my first couple of interviews, my very kind and gentle qualitative expert said, "Wow, that is just a really great quote there." And I beamed. And her response was, "The only problem is we can't use it because the interviewee had to have said that, not you." So onward and upward. Now, you may also have internal expertise that's ready to go, but there may be value in having an external objective evaluation team. That can be challenging if in-house expertise is strong and willing, but the political context is such that reliance on an external evaluation team would be better. My story here is really about a VA colleague who published an evaluation in a top-tier journal, which showed that the VA outperformed private sector healthcare in something like 295 of 300 healthcare quality measures. Not surprisingly, the agency quoted this paper all over the place while the media touted this external evaluation findings, ignoring that my colleague was actually also a VA researcher. In many ways, this was the best of both worlds as the methods were indeed rigorous and conducted at a think tank while benefiting from his expert knowledge. If you don't have internal expertise, then it's good to partner with other departments with such expertise while also seeking external evaluators. It's really good to get help. So I want you to realize basically that you have options. You can have an internal evaluation team that works within the agency and outside of the program that can evaluate the program itself. You can also build an evaluation team within the program so long as you think you can do this with enough of an arm's reach to remain objective. Namely, you have to be able to report good news and bad news. Or you can work with an external evaluation team that works with the agency itself. Or you can work with an external evaluation team that works with the program. Or you could have a combination. So I wanted to give you an example from some of my own work for one of my own evaluations where we had all the right expertise in-house for the practice surveys and the key stakeholder interviews up top and the administrative data which required use of our electronic health record on the bottom right. But we opted to contract out the provider and staff surveys with a leading expert at a nonprofit. We did our veteran surveys and the data and with a survey firm that checked all the boxes for veteran experience and also the data security that we needed. And we contracted out with a school of public health on the right side to conduct additional qualitative interviews with primary care teamlets so that in this case, we were able to leverage our in-house expertise with some external qualitative expertise so we could simply just get all the work done. So bottom line, you should do what works for your agency and your program. Now, there are varying perspectives on the value of an external evaluation team. Some perceive working with an evaluation team that's external to be faster and less costly. They may be able to staff up faster than the agency. I know from my own experience, federal hires can take a lot of time. I had a 3-year project and it took my HR group at that time 3 years to post the position. That was a problem. It may require changes to an organizational chart to actually be able to staff up, or it may be especially challenging to accomplish mid-year, and an external evaluator may not have those delays. An external evaluator can also dedicate staff to the evaluation, and perhaps they'll be less likely to be pulled away to attend to competing demands, or less likely to allow evaluation to become a collateral duty. An external evaluator may also be able to design and launch an evaluation faster if they've got prior experience. So if, for example, interview guides or surveys they've done for related programs that they can just tweak and adapt rather than develop de novo. They may also, flip side of the hiring issues, may be able to dial down the evaluation faster and easier versus, in our case, sometimes having to hire permanent staff. The flip side is that external evaluators may not be faster, or they may even be quite costly. Contracts themselves take time and experience to get right, and this is not a simple handoff. My job is done. Someone else is doing the evaluation. These kinds of external relationships require non-trivial oversight, engagement, and management. And I've had also university-based evaluators say that they have to go through regulatory review, like institutional review boards for human subjects protection, and that can add a substantial amount of time. Now, the plans for engaging evaluation teams require some pre-thought. And I would say the first step really in this arena is to engage your agency staff. And that includes topical and other relevant expertise within your agency and across programs perhaps, as well as those who are in charge of the outcomes and acting on them. So you need to be able to think about what the agency's goals for the program and its evaluation are. And that's relevant regardless of how old the program is, how long it's been around. And it's always good, I think, to revisit program goals and the assumptions that are therein. You also need to be thinking about the kind of evaluation information that would be useful. Is it process measures or outcome measures like we talked about last time? Is it comparative effectiveness? Are the agency leaders and program leaders needing to line up a variety of programs to really see and compare and contrast which one's most effective for what kind of groups, etc.? Do people really need a change over time, or do they need stories and testimonials, and why? By stories, I mean combining your statistics, which for some people can be either dry or given challenges and numeracy difficult to always understand, but instead create a more, using qualitative interviews, create a more understandable, meaningful, and often more powerful portrait of what a program's accomplishing, what it means to those who participate in their own words. All of this also requires thinking through what kind of resources are going to be available for evaluation. And in my experience, it's regrettably not at all uncommon for me to have to spend several meetings hearing about someone's new program and their need for evaluation, helping them think it through, only to find out that they in fact have no resources for evaluation, or that there's a bad mismatch between what they want and how far their resources are likely to go. So it's very important to be explicit. Now, in that context, you have to think about the scope of work and what the deliverables will be. This is, again, the value of setting an appropriate level and scope of the work. And this is true for internal and external evaluation teams so that everyone's on the same page. I also want to emphasize that you have to think through who needs to be at the table initially. For example, who's going to help you select outcome measures, and also think about how you're going to design the evaluation. And then think about who needs to be at the table later on, those people who can act on evaluation outcomes. I can't emphasize enough how useful that latter part is, because even though you may be collecting the outcomes they care about, you need to also know the kind of evidence they would need in order to act. I recall one of my early career folks completing a top flight evaluation of women veterans' access to and use of VA healthcare, and presenting her findings to the agency's head of women's health in an expert panel meeting to help come to consensus on what to do in reaction and response to her evidence. The good news, the bad news actually is that, to start with that, was that the agency found her work in a single VA network to be really high quality, but not useful for making a national policy change. So the good news is that they decided to actually fund her to take her work to scale nationally, so that they could then use it to make evidence-based practice and policy changes. That kind of win-win is what we often seek. In this context, it's important to develop questions for the potential evaluators and team members you may want to bring in, and decide how you will assess their qualifications, speak with references or clients, ask for work samples, don't be shy, or even consider whether or not you're going to do a request for applications and fully review proposals that come in along the way. Now, in my view, and again in experience, working with an evaluation team, whether it's internal or external, needs to be best done as a partnership. It's really important to be clear on the responsibilities of the agency and the evaluation and team, as well as the program. It's really important to establish useful communication approaches, the what, when, how, and wow, who's how, and who's on first for what. The frequency and the mode of communication should be designed to fit the agency needs. For example, I've had situations where the agency needs to report progress on a program on a quarterly basis, but didn't build in the time to make sure they could get the quarterly reports soon enough to review them, to edit them, to ask questions on the path to them taking that information up to the next level. So it's important to set those expectations up explicitly on how soon you need information for it to be useful for you to communicate up the chain or across to other agencies or organizations. It's important to be clear on what communication is needed. Do you want to know when there are problems with the evaluation plans or their implementation? Do you want to know the moment there are problems with the program, or are you the type where no news is good news? Personally, I prefer to hear problems early so that we can act on them. But every level of the agency and the program itself may need different trigger points for engagement. I also like to identify a communication pathway so it's very clear who is on point, especially in larger organizations. So is it clear to the evaluator to whom they ought to communicate for different issues? So I would just say it's important to make sure expectations around communication are included in a contract if you're doing something external, or in a within agency memorandum of understanding to minimize problems down the line. So in summary, in this area, the work plan and the deliverables need to be clearly communicated, and you need to know when there's a flexibility and where there may need to be consequences. Now, this is an important point. No one likes to assume there's going to be problems down the line in an evaluation, and the downside is that hope tends to lead to the avoidance of discussion of the what ifs something goes wrong, especially while you're developing relationships across teams, across programs, between an evaluation team and the like. And those relationships may last for years, so people tend to, again, not want to get into some of these potential consequences. But life happens, and in my experience, it is always better to walk through them ahead of the game. So I wanted to give you an example of how I've explicitly gotten agency, program, and frontline providers and staff to come to consensus on the kind of senior leader involvement that we think is important and feasible in the context of an evaluation. This may be overkill for you, but we literally surveyed those involved at different levels of the organization ahead of a group meeting to guide discussion. Similar questions you might pose are what kind of oversight is needed by the agency, who will be involved at the program level and how often will reports on progress be needed, and will you need consumer engagement? So these are just things to consider along the way. There are also many stakeholders beyond an evaluation team. So programs and policies, not surprisingly, have many stakeholders. There are the agency leaders themselves who may or may not be able to participate in the evaluation or any of these meetings I'm talking about. There are the program developers and the program leaders. Sometimes they're one and the same, sometimes they're different, as well as program staff. They're often very strong advocates for the program. They understand the program in details that are very important. There are also those folks who are the program beneficiaries and users, who may be patients and families or providers and staff. There are community members and community-based organizations, as well as other agencies that may be focused on similar problems that you're working to solve, and the evaluations that they may be conducting as well that you'd benefit from. There may also be topical experts from other programs, researchers, evaluators who want to learn about what you're learning in as much real time as possible. And then there are groups that you need to engage that oversee needed data. You're not going to get access to electronic health records easily without going through many layers of gatekeepers, or often getting access to administrative data can be quite challenging if you don't engage the right stakeholders along the way. So you can be the hub and spoke in something like this, where you're working individually with each one of these stakeholder groups, and there are times that that would be appropriate. But depending upon the size and diversity of your potential stakeholders, you may also want to consider a stakeholder advisory group to engage regularly. This provides a structure for regular engagement, collaboration, and mutual accountability. And there's plenty of research that's demonstrated that community engaged evaluation has many benefits. It can increase the way findings are implemented to bring about change, and it can increase inclusion of ideas, shared voice, and even more importantly, trust in the results. How long should an evaluation be? Well, I know I say it depends frequently, but it depends on the type, the size, the complexity, and the outcomes that you're seeking in an evaluation, as well as how long the program actually takes to implement or the outcomes take to be realized. So some evaluations can be quite brief, a matter of months, but that's typically only if the evaluation focus is very narrow and you've already been able to readily identify appropriate staff. So I have a couple of examples. One would be an evaluation of an educational program, which may only require surveys before and after completion of the program to demonstrate improved awareness and knowledge. Or a process evaluation of a program may only require tracking specific progress milestones towards putting program components in place. Perhaps they're easily accessible. And that may require a selected number of interviews and maybe some intermittent site visits, and you're done. There's also rigorous randomized evaluations, including pragmatic trials and other large-scale evaluations that can easily take 3 to 5 years. There are a lot of steps from planning and implementing to collecting and analyzing data before you even get to reporting. There are plenty of steps in there that also can take longer than expected. I have had a lot of experience where program implementation during leadership changes gets stymied completely and you have to be on hold while the program shifts its governance structure or has to rehire a new leader or things like that. I've also experienced delays and challenges in survey data collection when the response rates are quite low and require me to double the data collection period to make sure we get enough people responding to a survey for it to not be biased. And there are many more examples. So you need to be prepared for this kind of evaluation timeline. Now, some evaluations can also be quite extensive, 10 or more years. So if a program takes time to be implemented, and this I think about when people are building buildings, engaging lots of stakeholders, having to change policy in order to implement the program, standing up large numbers of staff and training them and putting them in place, then the evaluation itself adds time to that entire window beforehand to collect baseline information, during the implementation, and afterwards. I need to be able to collect and then analyze and report data well after the program itself is supposed to be done per se. Now, another example is if you're focused on something like mortality for a chronic condition, it can take many years to see any movement on the needle on changing patterns and rates. Or if you're relying on secondary data like vital statistics, it can take years before those data for a particular year or window are actually collected, cleaned, and made available for others for analysis. So you need to have some thought to those kinds of evaluation challenges and opportunities. The flip side is no program or policy can wait 5 or 10 years for results. So it's critical to have interim objectives and outcomes throughout the evaluation because it's going to be essential for program leaders, policymakers, and others to get those interim reports to make decisions along the way. It just simply can't be a black box and expect others to have full faith without early markers of progress and inroads on key measures. So basically, you need to build accountability in. Now, there are also types of information as a result that I wanted to mention that are needed at program and agency levels. The evaluation questions need to represent those program and agency needs. The common information needed by both are things like program progress on implementation and deliverables, including any early warning signs that things may be running afoul. And some of this could be integrated into contract language and scope of work if you're doing this with an external group. There are also typically demands for early results, especially if they're needed to continue or secure funding. That's important to be mindful that the kinds of information funders need have to be built into the evaluation. It may just be a matter of demonstrating how many individuals were helped, the kinds of services that were delivered and their volume, and early trends in outcomes, even if there's not a big increase or anything early on. It's just demonstrating that things are happening. Early results often mean formative evaluation, which we talked about last time, which also requires data cleaning, maybe merging, analysis, and reporting. So every wave of results that you need for interim reporting does mean more time and resources. So that needs to be built in as well. And then, of course, are the end results, either at the end of a program's life cycle or the end of the planned evaluation and funding. I always suggest inclusion of both quantitative and qualitative data to enable that storytelling, as I mentioned before. So I want to shift us to thinking about then defining program goals and activities, because that becomes the foundation for moving on the kind of evaluation you would want. First off, seems simple, but you do need to articulate what you want to accomplish. You need a clear goal statement, the difference you're trying to make. The goal is the outcome you're trying to change. And you have to think then about what kinds of activities and resources are needed to accomplish those goals. And think about the logical path from your activities that should lead to each outcome. And then think about, are the right contributing factors or drivers being targeted in program activities? In that process of trying to develop program goals and activities, you then also want to think about what else is out there in the literature or across agencies that may actually have been shown to be effective at achieving your goal, so that you have that mindset that there is in fact opportunities to learn from other programs, and you may be able to compare your program goals with others and consider adapting existing ones to your needs, but only if you think they are a good fit for your agency, your populations, and your context. So I wanted, in case it would be helpful, to share a sort of worksheet I often have people use to think about the drivers of the problem they're trying to solve, and think about how their program is linked to one or more drivers, and think about then the outcomes they can expect. It's often in this process of working this through that people realize their eyes have gotten too big, or that they can only really manage one or two drivers of any particular problem, and that they have to think differently about their program and its evaluation. This exercise also helps me better understand their intentions and their needs, which always helps me design a better evaluation. Similarly, I want you to think about the wide range of possible program outcomes beyond those that you may have planned. So here's an example to help that may be especially germane to our lives during the pandemic. One problem on the left side is that adults do not exercise enough. That comes with a sense that there are some people who indeed exercise regularly, but too many who are not. You want the regular exercisers up top to keep it up, and you want to get those people who are sitting on the couch or sitting in front of their computers too much to regularly start exercising at some point. And then you want the non-exercisers. The reality is that some non-exercisers are simply not going to change no matter what you do. And some regular exercisers may in fact slow down and stop, and perhaps illness or injury. But the bottom line is you want to make sure you're thinking through all of these possible outcomes when you're designing the program and conducting its evaluation, so that if you don't necessarily get all the outcomes you're expecting on the other side, you understand all the changes that occurred and why. So in defining program goals and activities, they need to be explicit and measurable. So I would say to say improving birth outcomes is too broad. I need to know whether or not you're talking about reducing low birth weight rates. Are you talking about reducing preterm delivery rates? Are you talking about reducing maternal complication rates? Or are you going so far as to focus on reducing maternal mortality? Then I'm going to push you on among whom. Are we talking about all deliveries? Are we talking about high-risk ones only? And if you say that, I'm going to say, well, how are we going to define how high risk? And then I'm going to ask you among whom. Is it an age group? Is it among teenagers? Is it among older moms? And then I'm going to press you again on where. Nationally, in specific high need regions, in rural hospitals, and how are you going to define that? These first areas where you're pushing on this is just to make sure that you can design an evaluation, again, that itself is explicit and measurable. Do we have defined outcomes, measures for outcomes of interest? In low birth weight, fortunately, there is a cut point at less than or equal to 2,500 grams. But if there is not some kind of recognized, validated cut point like that, you may need to do additional work with your evaluation team to figure out what kind of outcomes and what kind of cut points are going to matter for you. Perhaps not surprisingly, program goals should be feasible within some reasonable time frame, within available resources, and that too needs to be discussed up front. All of these steps affect the evaluation. Ultimately, the test of a good program goal is the ease with which evaluation questions flow from it. So if my goal is program A seeks to improve colorectal cancer screening rates in a particular state, the evaluation question is simply the flip of that: was participation in program A associated with improved colorectal cancer screening rates in that state? So this is why this program goal development is so important. Now, program goals may need to be multi-level, and there's a lot of details here. You can view at another time. But the key here is to be thinking about whether or not you can achieve your outcomes of interest by working at only one level versus working at multiple levels. So it may not be that you can solve the problems of interest working just with individuals, but perhaps you also have to work with families and social supports, and maybe not just providers and team members, but also their organizational and practice milieus. And maybe think about how they're functioning in their local community and state health policy environments and so on. If the program goals are multi-level, the evaluation needs to be as well. Now, every program has some theory, whether it's explicit or implied, of how and why it should work. Thinking that through helps you get the most out of your evaluation. For example, in theory, investment in preventive services should reduce service use and costs. But how? The thought was that a preventive services package in Medicare would actually improve individual beneficiary self-efficacy in how do they change their behavior, and changes in their autonomy, so they don't have to wait for a physician or someone else to tell them what to do. And that will actually change their risk behaviors, and if they change their risk behaviors, it'll improve their function, improve their health status, they'll even be more satisfied, and their pain will reduce. And all of those things taken in a series of steps should reduce service use and costs. Now, in this case, they relied on Bandura's social learning theory. Now, I was not trained in theory. There's some wonderful opportunities to look at theory at a glance and some other tools that we can make available. But in this case, they landed on this one that posits that people learn from one another via observation, imitation, and modeling, or what we would just call attention, memory, and motivation. So they then worked through a program that focused on recruiting providers and educating them on their preventive services, recruiting enrollees in Medicare and doing a baseline risk assessment, going through and providing health promotion and disease prevention visits and health promotion classes, working through with beneficiaries an actual plan for changing their behavior for one or more health risks, and then repeating some of the preventive services classes on top of a life satisfaction class, all on this logical pathway to reducing functional decline and utilization. And then the issue here for evaluation is it already gets me thinking about possible evaluation questions. Like, was the provider education in the far left column effective at improving their knowledge? Were the year 1 and year 2 preventive services with that behavior change plan actually able to improve self-efficacy, autonomy, and reduce risk behavior as planned? And was the program ultimately able to reduce functional decline and lower use and costs? So let me walk you through another example and take another step further. Now, in this case, this is a program process of establishing a goal to improve the use of highly active antiretroviral therapy among patients with HIV or human immunodeficiency virus disease. The second step after establishing that goal was to select drivers of the problem to target. In this case, based on the literature, physicians generally lacked at this time uniform knowledge of the antiretroviral therapy guidelines. They lacked clinical supports to adhere to those guidelines in real time, such as reminders. And there was some evidence that it can be hard to change physician behavior as new knowledge emerges. So the third step was to design program objectives that matched those selected drivers and causes. So the team in this case developed a physician education and training program on that therapy. They designed an audit and feedback program to share guideline adherence back to each practicing physician, comparing theirs to other physicians and other practices. And they gave them incentive bonuses to physicians who actually achieved benchmark rates of therapy adherence. Now, in this case, based on that process, I can begin to build a model of the program and its relationship to short and longer term goals, which again then helps me drive evaluation questions. So on the left, you have the HIV Quality Improvement Program with physician training, the audit and feedback of their actual practice on HIV care, the comparison to guidelines, and the bonuses. And then the early outcomes were these improvement in physician guideline knowledge, guideline adherence, and in this case, a focus on improving satisfaction as well. On the long-term path for the overarching goal or our primary outcome of improving the proportion of patients on antiretroviral treatment. So to show you how that process gets you to evaluation questions, we take each one of those to then say, was the QI program associated with higher physician guideline knowledge? Was it associated with higher physician guideline adherence? Was it associated with improved physician satisfaction? And was it associated ultimately with increasing highly active antiretroviral treatment among participating physicians' HIV positive patients? So I wanted to show you the one-to-one correspondence in this kind of effort. Now, as you translate program goals into evaluation questions, there are a few other lessons to be learned. As I said, just like with goals, the evaluation questions must be explicit, measurable, and feasible. So the first example is I always have people come in and say, did my program work? That's what I need to know. And of course, I have to push back and say, that's too generic. I don't know what work means, and I don't know how to measure it. So they may go back and do their homework and come back to me and say, was the Healthy Patient Program associated with better health outcomes at lower costs? This is something we call bundled. It's got two outcomes at the same time. You really need to separate those because it's very possible that the program could achieve better health outcomes, but it could cost more. So you need to be able to answer both questions separately. Or was the Healthy Patient Program associated with better health outcomes? Well, it's better than does it work, but it's still too generic because I need to know which health outcomes are going to be the focus. So of those, was the Healthy Patient Program associated with improved knowledge of healthy nutrition habits? That's the best because now I know we're after knowledge. I know what kind of knowledge we're after. The fact that they want to see an improvement tells me that this is something I'm going to have to evaluate before and after. So that's a study design issue. And there may also be room for us to compare this to a group not exposed to the Healthy Patient Program, which of course is more work as well. Now, I want to make sure that you remember that just like there are outcome measures, there are process measures. We very often want process evaluation questions as well. So these address, again, the program operations of who, what, when, and how. So some examples, were the program activities accomplished overall or with the intended frequency and intensity or dosage, if you will, of the program? Were they accomplished on time? I don't need statistical significance for a question like that. What was the quality of the program components and how well were they implemented? What was the intended target population reached? I have had programs where they sought to get high-risk teens, but they ended getting low-risk, later age individuals, which meant that they missed the mark. How did external factors influence program delivery? Did our assumptions hold up about how and why the program would work? I showed you that model for the HIV program. Is the logic actually work? We thought perhaps the nature of the problem was X, but based on that assumption, we further assumed that doing A, B, and C would address that problem. Were we in fact right? Or were there other factors of which we were unaware? Or was our logic based on outdated thinking? When I think about the HIV example, there is one very big thing missing in that model, and that is that it's all focused on changing physicians, but there's nothing in there about the rest of the teams that ensure that good quality of care is delivered. There's also nothing about the patient and focus on compliance or their understanding and awareness. So process evaluation questions can help us in those particular areas. Next step on this then is thinking about standards of effectiveness. So we've got a series of evaluation questions. Now we need to know how to answer yes or no. And it's to do that it's best if we have preset specific criteria on how to answer each evaluation question. Now, when we think about program merit or effectiveness, it's often set by one of several standards. It may be statistical significance. For example, program A improved continuity in 1 year and we get the P less than 0.05. We go, oh great, it's statistically significant and in terms of whatever its change was. Or we may have program A improved access statistically significantly better than a comparison program. That only works if those two programs, the program of interest and the comparison group, are reasonably comparable, meaning they serve about the same risk patients or in an area that is somewhat similar to the area in which the program is to ensure you're comparing apples to apples. You may work on normative comparisons. For example, you may have no way of randomly assigning people or identifying a region that's like the one where you need to develop and implement and evaluate this program. So in one example, we had a program that was focused on improving the low birth weight rate among participating teens. And again, there was no comparator. So we compared the program's impact among these high-risk teens compared to the entire county's low-risk, low birth weight rate. If they could improve it better than that, that was quite something. And sometimes we don't have comparisons or statistical data available, and so we use arbitrary standards. For example, perhaps you want to set up the standard that at least half of Program C participants will engage in all program services. If they don't, that means the program was not effective in that area. Target setting for progress and end goals is key, and that's one of the more important takeaways I want you to have here. It communicates the expectations and priorities for progress on key outcomes. And I want to say the flip side to all of this is that it's really important to avoid perfectionism or excessive advocacy. No program is all things to all people. If you think about it, you're never going to get 100% of teens to change behavior. It makes me think of a school-based program that I learned about in my son's school years ago in high school, where outside of the magnet program in which he was being educated, the average reading level was at the second grade level in high school, second grade. And one of the teachers developed a reading program to intensively help these students. And within a single semester, he managed to bring their reading levels up from a second grade level to an 8th grade level. But the district and other leaders had set up the standard that those students had to make it to their grade level in a single semester. So the program was decided to be a failure and they concluded it. So you don't want to have those unintended consequences along the way. Now to go back to the HIV-QI example, I wanted to provide you with some example standards as well. So was the HIV-QI program associated with higher MD guideline knowledge? My standard there is I want to see a statistically significant increase in knowledge among those who participated. For the second evaluation question, was the HIV-QI program associated with higher MD guideline adherence? In this case, I want to see a statistically significantly higher level of guideline adherence after participation. And in this case, I want a higher level of guideline adherence among those who participated in my program compared to people in another comparison group, which also means I have to collect data from both groups, which we'll talk about more next time. The third evaluation question, was the HIV-QI program associated with improved physician satisfaction? In this case, you don't have to stick to a single standard. You can have more than one. So in this case, I wanted a majority of the physicians to report the program as mostly to highly acceptable. That's part of my thinking about implementation evaluation as well. And I want those physicians that were part of the program to, again, have a statistically significantly more satisfied level of reporting than comparison physicians. And then lastly, my gold standard, my overarching impact goal is that, in fact, this program was associated with a change in the volume of patients with HIV disease getting highly active antiretroviral therapy. And there I want to see a statistically significant increase in the percent of patients receiving that therapy within the first couple of years of the program. So I wanted to make sure you have those kinds of examples in hand. Now, let's say we go through to the other end and you have to decide now whether or not the evaluation questions have been answered. You've gotten your statistically significant results. And you're going to go celebrate, but I'd say it's still critical to lift the lid on those findings. And this is also where there's value of expert and stakeholder input in assessing evaluation evidence. And that we'll talk about in part 3. In the meanwhile, I want you to consider all the results that you get. Has a single outcome of, say, 4 or 5 outcomes demonstrated statistical significance? Or is it really a mixed bag of results where some things worked and some things didn't? Or it worked for some areas and not some others? I would say then, ask why it did not work as intended for all the outcomes to guide your next steps. I would also think about why did some outcomes improve much more or much less than others? And what does that mean for the program or the policy? Does it make sense for the program to have had the outcomes noted? Sometimes we see programs have incredibly strong outcomes in areas we weren't necessarily expecting. That's worth exploring further. Are there subgroups? This is really important. Are there subgroups for whom the program failed to work? If yes, what can you in fact do about it? Can you talk to those for whom it did not work? And can you use that evaluation information to help the program further tailor itself? Or are there statistically significant improvements that are simply not so clinically or programmatically meaningful? That's most important in really large programs, Medicare, SNAP, these things that have tens of thousands or hundreds or thousands or millions of beneficiaries and program participants, where the sample size, if you will, is so large that a tiny smidgen of a change drives statistical significance, but it's not enough for anyone to get hugely excited about unless it's on the path to bigger changes over time, perhaps. And lastly, were the analyses done in a way that minimized bias and were key other factors that could have driven outcomes adjusted for appropriately? Now, in this particular series, we won't be getting into the statistics, but again, here's an opportunity to bring in others to help you understand whether or not these are issues in your evaluation. And lastly, I want you to think about the information that's needed when and in what forms. I foreshadowed some of this earlier in today's talk, but again, it's best to predefine what you need when based on agency and stakeholder needs. The common information that's needed here is the program description, its purpose, its goals, its setting and context. This is information we talked about last time as not being evaluation, but it's still important information. You often need to start talking about program progress, especially if it's a new program or changing. And that's where we think about process evaluation, the organizational chart, the documentation of procedures and policies, the staffing, the services delivered. We also often have to report on information about the characteristics of those who participated in the program, which we'll talk about a bit more in part 3. And of course, everyone wants to know early outcomes if they were collected, and of course, post-program or later program outcomes and any changes that were had. And here's 2 that often aren't mentioned off the top, and that is, it's important to know something about people who were lost from the program, meaning they started and didn't continue, because that's useful information on either something else that needs to be done to retain them or something they didn't like about the program that you may need to think about changing to ensure equitable access to the services that were going to be provided. And maybe a summary of the challenges they faced could be delivered as well. And then you need to be thinking about unintended consequences, good and bad, along the way. This is a lot of pre-thinking to do about what you would need from an evaluation and the kind of evidence, but it is always necessary because I have also been in many situations where after programs completed, we simply don't have adequate information based on what people learned along the way. Hence why this is group and team processes. The format for these may vary as well, thinking about briefings, slide decks, infographics, visual abstracts. Each group of stakeholders may need something different, so we often need to be thinking about, just as I talked about how often we communicate, It's what kind of information our different stakeholders and agency groups need along the way. So with that, I'm going to conclude that portion and make sure we have time for Q&A.
Thank you so much, Dr. Yano, for such a good presentation. We do have a few questions. We'll get to as many as we can. Those that we don't get to, we do plan to have all of the questions and a sort of questions and answer document that we will post along with the recordings and the slides and things like that. Our first question is, are there stakeholders that you would recommend not including on the evaluation team?
Outstanding question. I would pose it a slightly different way and see if I get to your interest. I would say that the evaluation team needs to participate and engage many stakeholders, but they may not be fully on the evaluation team. At the end of the day, the evaluation team has to be objective and be able to deliver, as I said earlier, good and bad news. So I have noticed in some participatory evaluations where you get to know everyone in the program so much that you have to be careful to not let it bias the answers you're about to deliver. And so it is one of those circumstances where you want to have people participate and engage in steps along the way, but not always be an actual member of the evaluation team. There's also the perspective of making sure that there are some, I'm thinking about if there are any other situations where stakeholders, there would be people you would not want on the team. I think if anyone's unwilling to hear bad news, you may need to hold them at arm's length.
Thank you. Another question is, are there ways to ensure the program goals are culturally competent? And I think we will put a more thoughtful and complete answer in writing, but if you could just touch on this, Dr. Yano, we'd appreciate it.
Yeah, another really exceptional question. I think all of this pre-planning I'm talking about throughout this is in some ways insurance about making sure that there are explicit opportunities to make sure the program goals and the evaluation goals are culturally competent. I often press on people to think about every single evaluation question and think about its implications for stakeholders, its implications for groups that are marginalized or underrepresented, and to think about how we're even posing questions and surveys. All of that work requires intentionality and time, and making sure that the right people are at the table that, to be quite honest, poke me and poke others to make sure that we're framing these things appropriately, measuring things appropriately, including additional measures we might not have even thought about before. And so it needs to be an explicit part of this entire plan.
Thank you. And we do have other questions, but we're running short on time. So we do want to put a poll here to get your feedback, because we are evaluators. We want to evaluate our performance here.